Hello and welcome to Everyday Oral Surgery. This is your host, Dr. Grant Stucki. I am an oral and maxillofacial surgeon practicing in Denver, Colorado. The goal of this podcast is to connect, learn, and inspire. In this podcast, you'll be hearing from OMS surgeons all over the globe discussing ways to improve the practice of oral and maxillofacial surgery. Most information shared in this podcast will be based on personal experience and opinions, so please supplement what you learn here with approved research studies. Without further ado, please enjoy today's episode. All right, welcome back to another episode. Today I'm with Dr. Vic Martel. He is a general dentist practicing in Florida. Vic, thank you so much for joining us on the podcast again.
Yeah, it's great to be back. I really appreciate it. I think this is going to be some interesting information for a lot of your surgeons and your restorative dentists also. So,
yeah, for sure. Today we wanted to talk a little bit about congenitally missing maxillary laterals. We haven't really discussed this in an episode, like specifically in an episode, so I think this will be a good topic. Can you just tell us a little bit about how you came up with your protocol?
Well, in two ways. Number one, during my mini residency programs that I teach, I've always had at least a half a day, sometimes a day, on anterior implants. And of course, obviously, this topic is within that topic. And it's always been something that once I get to this part of the day, a lot of people, including the surgeons, are very interested in hearing this. So I have to kind of slow down and really go through it because it's something here's the bottom line. It's going to affect everybody, meaning, how I really talk about this is very few people or orthodontists are moving canines in the lateral spots anymore, right? I mean, you're too young to know this, but in my day, that's the way they did everything, right? It was always just orthodontically move the canines in the lateral spots because we weren't, as adept at doing aesthetic implants in the anterior. So I think today, now it's the opposite. I think probably 90% of cases, maybe more, where the orthodontist is just leaving space. And ultimately, within that, this is one of the few areas, and maybe I'm wrong, and you can help me with this, this is one of the few areas of implant dentistry that definitely involves interdisciplinary. I mean, you need a orthodontist, right? You need the restorative dentist, and hopefully, the way I would talk about it, you need a surgeon that's going to do what do we need him to do, and so it's two things. It's almost always interdisciplinary, but it's one of these rare things that goes over time. Normally a patient walks in, you take a tooth out, you put an implant in, or you take all their teeth out, you put 4 to 6 implants in, and within a few months, they're done.
Right.
This is years and years. And as a restorative dentist, especially GPs, probably not as much with prosthodontists, is we tend to treat families, right? And a lot of times within that, if I see their parents, I certainly see their kids. And with that brings this, almost like, well, we need to, first thing I've always done. And, you had a guest quite a while back that was it was a female orthodontist, I think it was. And, And it was, she really talked about really looking at everything from a standpoint of, and she was saying, I think back, I can't remember quite the conversation, but it seems like a brilliant dentist, and was talking about we should start checking these young children earlier and earlier and earlier, as far as looking for growth issues, narrowness, airway issues, and within that becomes this issue of, looking for missing laterals, which is super important because that's when we need to train better on these kinds of things. So let's see if I can. Okay. There we go. Okay. So therefore, in my mind, and my orthodontist, I think I've told you this with other specialties. I have this one orthodontist, and I'm insanely loyal to this one person because he does everything the way I feel it should be done for my patients. And I always ask for advice. Is, when should we start checking kids for missing laterals? And his idea at that time was like, about, if you have a digital pan or a cone beam, you can do something at about 9 years old. And that's fine. It was great advice. But I think now we're actually starting to look even earlier, which is fine. But it becomes this part of the initial protocol of when do you at minimum start looking. Now, what I did was, from a CYA standpoint, I would take the x-rays But then I would send it to the orthodontist and say, you go ahead and count the teeth. I'm not going to be the only one looking at this case, to make sure the laterals aren't there and things, so that we at least form a plan. And this is where my protocol came from, because there was so much inconsistency, or maybe not inconsistency, but people not talking about all the different steps in this, from initial diagnosis to implant placement. And every time I did this lecture, I said, one of these days I really have to make a handout about this, so that I can send it to my specialists that I lecture with. They can send it to their restorative dentist, so that all I really care about is, my protocol isn't perfect, but everybody needs to be on the same page. That's really what's important. Your specialist, your orthodontist. And here was the interesting side of my programs, Grant. We actually, even though it's a program on comprehensive treatment planning, we would always invite orthodontists to them, not just the restorative dentist, because we want a treatment plan, what you would call in your world grand rounds. We want a treatment plan comprehensively. So, of course, it was advantageous to have an orthodontist there. And through that, I actually saw that, I've done this, at this point, hundreds of times. I actually saw that not every orthodontist for this type of treatment was kind of up to the new standards of what we should be doing. I'll give you a perfect example. Something that you and I may, take for granted is, how many millimeters of space do I need between the laterals, between the centrals and the canines, and what's good enough, and what's a minimum. And I have at the end, I'll tell you a story that we had, because I ran into this problem a couple of times with different orthodontists. But ultimately, we need our orthodontists to be trained in this field so that they're on the same page. We need the restorative dentist, and we certainly need the surgeon to be on the same page. So this is what brought all this on. So in essence, step one of my protocol is initial diagnosis. When do we do it? And my protocol says, 7 to 9 is probably really, really good. And then from there, where do you go? Do you sit and wait? Do you not? Excuse me, Grant, if you have questions, and feel free to interrupt me, because I know there's 5 or 6 steps here, and I don't want to dominate this. But that's the initial thing, is finding out and looking for those kinds of problems, because when you start looking for them, at least you can inform the patients. You may not do any treatment at that point, and you might do some, expanders, some functional appliances. Maybe you will. It depends on the narrowness of the arch and all those kinds of things. But at minimum, we want to know what's going on, so that we have an orthodontist in our team, our interdisciplinary team. And ultimately, although you may not see the patient as the surgeon right away, we need to get all our ducks in the row, so that everybody's on the same page. And for example, in your case in Denver, I would hope the first thing I would do is I'd say, Grant, who do you use mostly for ortho that is really up on all this type of thing? Because we want to create this team that everybody kind of is thinking in the same direction, so that we know about when we're going to do this or do Y or do Z, so that we get everybody, at least all our ducks in the row. So when we inform the parents, they know what to expect from that point on.
I like that. All right. So let's say you catch a patient, around that 7 to 9 years. You inform the parents, because like you alluded to, a lot of this is holding the hand of the parent. The kids themselves probably don't even care until they're a little older, but trying to teach the parents what the process is going to look like.
Yeah, that's, and in fact, probably 95% of the conversation is to the parents. So what I would do is I would, take the cone beam or the panoramic digital pan. I'd have a conversation. And what I do first is once I did that, and I don't necessarily, and I wouldn't recommend this, once you take that x-ray, even as the restorative dentist, if the parents are there and you're, and the child is just in for a cleaning, for example, not a good time to have this conversation. Okay. And the reason is it's too spontaneous. So what I would do is I send I send the scan over to the orthodontist. We verify that those are missing. And then I call up everybody and I bring them in for a no charge consult, put them in the consult room, and I sit and have a conversation. And I don't mind if the child is there, but if you think about it, if they're 9, or like you said, they don't really know what's going on. Most importantly, I want the mom and the dad both there. Why both? Well, I hate to sound negative, but guess what? Parents get divorced sometimes, and I want the dad and the mom to be on the same page. Mom comes and the dad's not there, and things change through conversation, and mom may say something that I didn't say, or all those kinds of things. So ultimately, the communication at this point is super important. So what we do is I bring them both in, and if they're divorced, I'll bring them in separately because I just want to make sure they're getting really accurate information. And what you're going to, Grant, do you have daughters?
Yes.
Okay. So, and I don't, I have sons. But here's what I do know from all my friends that have daughters. Dads are very protective of their daughters. Okay. I'm probably going to have a little bit sterner conversation with dad if it's a daughter than I am if it's a son. Why? Because little Susie's going to run into 15 years old and she's going to want to go to prom and she's going to want her braces off and she's going to want this or that. And it's really hard for dad to say no. I get it. Okay. Yeah. So if I set up all these criteria when they're 10, I can look at dad and say, Dad, we talked about this, this is, so, and what I was just saying to you before we got on is I'm actually as we're speaking, in the middle of creating a parent handout with everything that I'm talking about today for parents. Why? In Florida, everybody moves all the time. And guess what? I want them parents to bring that sheet with them to the protocol if they move to Michigan or whatever, because I want them to have the same type of protocol and team there as opposed to someplace else. Because I don't want them, now the dentist said, the dentist in Michigan told me I could have my implants at 13 years old. Right? No, you can't. So I'm creating a handout, but what I'm doing at that stage is this, and this is goes into the next step of the protocol is I want the parents to know, all right, little Susie's missing her upper laterals. That's one thing. The other thing that I tend to do is, and this is purely for a convenience for the parents a little bit and a lot for me, I would want my orthodontist to slightly delay ortho, meaning, the average a kid gets out of ortho at 14, right? Let's make it 15. Maybe delay it a year or keep the ortho on longer. Why? Because especially with a female, they might be ready at 16. They might be ready at 17. So they're not going to have this huge gap. If we're done at 15, at least they're not, really bothering the parents about getting these off because of this situation. Now with the male, we know that that's irrelevant because it's going to be 21, 22 that we'll talk about in a little bit. But ultimately, so the first step is I want to delay it a little bit, just for the sake of I don't have that as big of a gap. What else am I telling the parents? I'm going to tell the parents, and this comes later in the handout, that, when the braces come off, the surgeon, the orthodontist, and the restorative dentist are going to evaluate the patient, your daughter or your son, and do measurements and determine how much space we have and all those kinds of things, and whether or not the space created is a good space for an implant. That's the next thing. And I'm jumping ahead a little bit, but ultimately the other thing I'm going to tell the parents, and I get it, they're not going to remember all this. That's why I'm going to write it down. And I use it in layman's terms. And I said, and you know what? There's a good chance when we're ready for these implants, and Susie might be 16, 17. We don't know. It depends on your growth, the way you grow, is we might need adding some bone in that area because those areas tend to be very thin boned. See, what I'm really trying to do is I don't want them to ever get to the point where Susie's 16 and say, you didn't tell me that. You didn't tell me it was going to be like this. So I really want to give them that, even though I fully understand they're not going to remember all of this. That's why it's going to be in writing. So because I want to cover you, Grant, and say, when you tell them you need a bone graft, they say, oh, yeah, I remember that. We're going to have to add some bone there and things like that. That's right. Number two, I need to prepare them for Susie or Billy, especially Billy, is going to need a fixed retainer. What do I mean by that? I don't want them in a Holly. I don't want them on an Essex appliance. I want the roots splinted because I don't want root movement. So we're going to do what we call these little temporary Maryland bridges. Okay. And why? Because it's going to be an expense for them, right? No, I don't know. I don't tell them the fees because it's too far ahead, but I want them to be prepared if the restorative dentist says, listen, we need to do these little bridges there so that the roots won't move. So by the time they're ready for their implants, we're okay. And during my lecture, I actually even show them a photo of the type of Maryland bridge I prefer based on my mistakes in the past, and that's called research. So here's what I mean. I want, and this is what I actually show pictures of this. I actually want and there's a reason for every part of it. I want a non-precious metal Maryland bridge. And I want the wings to have retention holes all the way through it. And here's the reason. Number one, I want to be able to take these Maryland bridges off and on. If you want to do the implants, if you want to evaluate, I want to be able to pop them off and on. Non-precious metal won't bend. So if I pop them off, I'd be able to put them back on.
Got it.
So the wings are important because I'm not going to etch the metal. Because if I etch the metal, I'm going to have to cut the Maryland bridge off. Those are mechanical retention holes. So I may put some composite on the linguals of those two teeth, and I'm going to push composite through them and then smooth it down. So it's only mechanically retained to the teeth, not etched and bonded to the teeth. Because I want to be able to get them off without destroying them. Because I don't want to charge the parents for 2 or 3 sets of Maryland bridges because the patient wasn't ready yet.
Yeah.
So ultimately, that's the situation with the Maryland bridges. And then I tell them, listen, other important thing that's in the protocol, if this little thing ever gets loose, because don't forget, where are these kids at this point in their age? College, they don't notice or care about the wing came loose, and all of a sudden they come back and one of the roots has shifted. And now you have a very unhappy parent and child, because when I look at them and say, the ortho's got to go back on or you don't have any room for an implant, that's not a good thing. Okay. Yeah. That's why Hawleys and those kind of retention don't work, because they may keep the crown in place, but it doesn't keep the roots from moving. Right. So the last thing we would want as a general dentist or a restorative dentist, wouldn't want them to have them give them an Essex and they come back however many years later and they say to me or to the dentist, I wore this religiously. And then I'm looking at them and say, well, your roots moved. I got to send you back an ortho. That makes the restorative dentist look really, really bad, just because he happened to pick the wrong retention. Okay. In essence, what you need to think about is this: it's got to be fixed and splinted. Now, the last thing I tell the orthodontist, and this is where all the planning comes in, if I'm going to do Maryland bridges, I really don't want to cut preps into the linguals of the teeth. That I just have an aversion for cutting enamel that doesn't need it. So I'm going to actually have them shallow the overbite a little bit when they finish, so that I have, in other words, don't give me that normal overjet overbite. Give me a little less.
Yeah.
Have room for non-prepped wings in the case. So ultimately, the preparation is Susie's probably going to get her implants at about 16, 17. Billy's probably going to get them at, we're seeing studies now that the males are growing till 30, but I'm not going to make that happen. I'm going to say, 21, 20, 22, depending on the growth of the parent. And then lastly, I need to have verified, my personal choice is I want comparable cephs to determine the final growth. I don't, even a little bit in the protocol, I don't want anybody to go by shoe size, menstrual cycles. Those are nice things, but they're not solid, because we really want to make sure that the growth is close to being done. And I've had some pictures when in my lecture I inherited a couple cases where a male patient had an implant put in at 16 and he's 25 now, and it's an absolute disaster. Way higher than the rest of the teeth, and it's something that, as I'm sure getting that implant out is going to be much more destruction than waited. So, yeah, those are the pre's. Do you have any questions at this point, or I'll keep on?
Yeah, this is good. A couple questions. One is, at what point do you see the retained primary teeth coming out? Like when are you dealing with all of that? At what age?
That's a great question. I mean, believe it or not, and I have orthodontists that do it one of two ways. They kind of keep them for as long as they can. On the other hand, as well as I do, sometimes they get loose, because of the other movement of the laterals and canines that maybe move the roots a little bit. But in any event, I actually show a case in my anterior lecture where we went from, child all the way through implants. And as long as the orthodontist can put, which is another part of the protocol, they put, denture teeth or composite teeth on the brackets and things like that. The reason I like that as well is it gives a better proportion to the case. You know what I mean? Yeah. I would like an ideal shape and size, width and length of that lateral incisor, and the orthodontist has a much better reference point of moving the teeth mesial, distally, anterior, posteriorly. So I'd rather have something there that's more templated for what's going to be there in the future. So that's what we do. Every orthodontist is different. I tend not to like to step on their toes a little bit. But in essence, as you know, as well as I do, I always say to the restorative dentist, what you need to understand about most cases, especially these, you're the quarterback. You're the one that when the teeth go in, the implant teeth go in, the only person they're going to look at if it's ugly is the restorative dentist. Because the surgeon can say, well, the implant's integrated, and the ortho said, well, I gave you your space. And ultimately, my feeling is if the patient has to look in the mirror for the next, and don't forget, 50 years sometimes, right? And if they look at it and they love it, then they're going to thank me. If they look at it and they hate it, I'm going to get cursed out all the time. So I always tend to kind of want to be more careful because I'm the one that's kind of like in charge, or the quarterback or the conductor saying, okay, it's time to go to the orthodontist. Okay, it's time to see the surgeon. And ultimately, that's where we go to the next part of the protocol is when is it time to see the surgeon?
Yeah.
Now, what I would do, and Grant, I don't know what your office does, I would really prefer in the midst of their ortho, let's say they're 13 years old, that's when I would like to at least send them over to get a consult with you and take a look at what you're doing. You can take a look at where they're probably going to need a bone graft. Let me ask you a question. What do you think the percentage of those types of patients needing bone grafts in those areas?
That's a good question. I mean, I don't have my own data, but it's probably somewhere around 50%. I mean, a good portion will need a graft.
And it's always better to prepare the parents and then not need it, right?
Mm-hmm.
Than the other way around. It's
Right.
It's that old adage. If you give them if you tell them something beforehand, it's information. If you tell them afterwards, it's an excuse, and we don't want to do that. So what I would say to the parents, and I actually tell them this at the beginning, when Billy or Susie's at about 13 or halfway through their ortho, we're going to send you over for a consult and prepare this for implants. Now, here's the good news. If you have my protocol and the orthodontist has my protocol, and the parents kind of understand, everybody's on the same page. So there's really no kind of, oh, I didn't know that. I wouldn't have done this if I didn't know this. And you want to eliminate all that because this is a stressful situation because it's so long-term anyways.
Yeah.
And ultimately, all I care about is, oh yeah, that's what Dr. Martel said. So I understand that. And you have, obviously if I was dealing a case with you, I would actually have that parent handout for you too. So you kind of know exactly what I told them at a certain point. But let's say, for example, now you did a consult and you're looking at, how much space is there, obviously, what their occlusion looks like, how much bone is in that area, whether you need to do a bone graft and things like that. And then ultimately we sit and wait until the ortho's done. And the other thing is, again, repetitive information. If you also say to Grant, well, Billy's not going to be ready for these implants until he's like 2021, they've heard it again. So it's this confirmation. It's constant confirmation.
Yeah.
It has to happen with the orthodontist, and this is a super important. Okay, and this is where my unfortunate story comes in. And I created I think I sent you a copy of it. I created what I call a release form. And here's what a release form is. It's really simple. It's one paragraph, but everybody gets it. The surgeon gets one, the orthodontist gets one, and the restorative person has one. And all it says is this: all of us agree that the orthodontic braces cannot come off until we all have looked at the case and agreed that it's okay. Why? Okay. To make a really long story short, I had a female patient come to see me for implants in the lateral positions. She was 40-something years old, so growth wasn't an issue. And she wanted implants. I sent her to an orthodontist, not the one that I use now. And you would understand that in a second. So what I didn't know is the same patient had a different general dentist than me. I didn't realize, she never told me that she was only coming to me for the implant work.
Okay.
The problem was all the letters from the orthodontist went to the other dentist. So I forgot about it. 2 years later, in our morning huddle, I see her on my schedule. And I go, oh, where's she been? Well, she's just finished her ortho and she's ready for her implants. And she just got her braces off today. and my stomach turned. Of course, we take the x-rays, and one side has 3.2 millimeters, the other side has 4.2 millimeters, and the braces.
Oh boy.
We look at the patient and go, you need to go back in braces. And she's very upset, of course.
Mm-hmm.
That's not the half of it. I was flying out to do a lecture that afternoon, so I didn't have time to call the orthodontist. I wrote a little note. I took a digital x-ray, printed it out, wrote the measurements on it, and sent to the orthodontist, "Dear so-and-so, can you please put the braces back on?" This was like a Thursday afternoon, so I wasn't going to be back in town till Sunday. Well, come Monday morning, I was going to call the orthodontist, but I thought I'd be a little smart. And let me call the patient first and see how it went. So I called her up and I said, "How'd it go?" She goes, "Not good." And I go, "What do you mean?" He said, "As soon as he saw your note, he said to me, 'I guess you're going to get 2 3-unit bridges because I'm not putting the braces back on.'"
Okay.
One, he's fired. And number two, to this day, I don't know what she ended up doing because she went back to her other general dentist. So that was the purpose of creating this form. This release form is like, all right, from now on, these braces aren't coming off. And what it is just a little paragraph. I think you see it. And then it has signature slots down below. And until all 3 signatures are on that form, the braces are staying on. Why? Because it's a lot easier to keep the braces on than to take them off and put them back on. Nobody wants to get braces put back on, but there's nothing wrong with saying, "I think we need a little bit more time."
Yeah.
This is where all that comes in, is the point of creating space. And we all know we need 6 or 7 millimeters of space. We need the roots to be splinted. So those are all the things that, we talk about in the protocols. And then now it's implant time. Let's say it's one of my sons. And what's your normal experience as far as males? What do you feel comfortable with? Because there's no right or wrong answer, but every surgeon I find is a little bit different as far as that's concerned.
Talking about age to be ready for an implant?
Right. Yeah.
Yeah, I mean, for us, usually we're saying 18 for girls, 20 for boys. I mean, that's kind of the general.
Yeah, I think that's a pretty safe bet. I think 20, you might still see some growth, but it's not going to be so much growth that it's going to be noticeable. Meaning, the implants, we also obviously know they're ankylosed and the other teeth, because we know that the premaxilla comes down and forward and the size edge positions change and all those kinds of things. So I think that's safe. I mean, when people ask me, I say this: if this was my son in the chair, okay, the good news is in my house, there's no democracy. That's like, I'm going to say to my son, he goes, but I want my implants. I go, well, I don't remember asking you. You're going to get it done when about 21, 22, when I know it's safe and we're good, And then if it was my surgeon, I want those cases guided. Why not? It's in the front of the mouth. Why wouldn't you put it exactly where you need it? And then even before that, I don't know if you've ever read this article, lit article. And if not, I'll send you a copy of it. You ever heard of the 3A, 2B rule?
Remind me, what's that about?
So it's a lit article. It's written by Fernando Rojas Vizcaya. He's an interesting guy. He's out of Spain. He teaches courses, but he is a oral surgeon prosthetist. Very unusual combination. So, but what it is this. Of course, we always know that 3A means 3 millimeters deep or 3 millimeters apical, right? 3A. 2B is 2 millimeters from the buccal plate. Of course, we know that. But he takes it one step further, and this is what I've always done, and I teach this restorative dentists to do. Let's say Billy's in your chair, Grant, and you're ready to put the implants in. And what you know as well as I do, and what every surgeon knows, when you have missing laterals, the bone is thin, most likely, but it's also a little too incisal. The bone comes down a little bit further than it should. Yeah. So what I always do in those cases is I actually create, now it could be digital, but I want a wax up done of where the cervical top of my porcelain needs to be aesthetically.
Yeah.
Okay.
Why
do I want that? Because it's going to be deeper than where the bone is when when it's too incisal, right?
Yeah.
So I'm going to do that. I want on the guide. Now I want you as my surgeon to put the implant 3 millimeters apical to where I want my final porcelain to look. Okay. It's not just put it in, it's put it in 3 millimeters deeper than where I want it to be.
Got it.
Ultimately, that's a more of a guide because, years ago when we didn't do that, you put implants in those lateral spots, and a lot of times, I don't know if you've ever seen these kind of cases, they kind of look short and stubby. So aesthetically, or they look too square and not rectangular. So it's something that's just not right. So he came up with this, and he does it with every case he does. He's a brilliant guy. But like I said, I have an article on that. I can send it to anybody as well. But it's really interesting reading, and it's just a matter of being accurate as far as the placement's concerned, so that aesthetically the case belongs where it does in the long run. So, that's that type of case. I'll let you ask any questions from that point on, but we can keep on going.
This is great. I mean, really important that we get the right space that you're talking about, set up the width with the orthodontist. Because I'll get multiple orthodontists, that have their patients in the braces, and they'll send them over, and they're saying, hey, can you look at this and tell me, is there enough space there to do an implant someday? And so I feel that's a very common thing. Like, they're confused. They don't know. They don't have a great idea. But like you're saying, I would say minimum 6. It would be much better if we got 7 millimeters, because, and I mostly work with the Nobel BioCare system, and I'll tell you my experience is that I want to get at least the 3.5 in there. They make a narrow 3.0, and I know some implant systems even make a smaller, like 2.9 or 2.8 or something.
2.9. I think the Nobel has 3.0. But I mean, it's still, when you're talking about 6 millimeters, and you and I know these things. I need to be 1.5 millimeters away from each root, right?
Yeah.
That's 3 right there. Okay. Now I have a 3 millimeter implant. I always, my joke is, let's just hope Grant hasn't had too much coffee that day, because so just give me 7. Let's just be safe. And once the braces are on, or we can still move things. You know what I mean? That's the downside of doing this. So then what I do is what you just said, is I'm looking for space, and ideally I'd like 7. But if the orthodontist says, listen, the best I can do is give you 6.5, I'll go, that's fine. And if it turns out to be 6, but if it's 5.5, no, we're not going to deal with that, because it's you're threading the needle too much for that. And then lastly, what you may not have looked at that I'm going to look at is the bite a little bit more shallow? Is the overbite not as deep as they normally would? Because I know that I'm going to put Maryland bridges there. And then lastly, I know as the restorative dentist, once the implants are in, and we can talk about this next if you want, is I'm going to handle the occlusion differently on an implant and lateral position than I am on a natural tooth and central canine position. It's just a must. And I don't think enough restorative dentists, maybe the highly experienced prosthodontists, think about this. I don't know if the average restorative dentist that does these kind of cases, because they don't do them as frequently, really understands how to look at the occlusion on these things, so we don't end up with chipped, porcelain, or worse yet, a problem with the implant itself. So
yeah. I mean, one question for you is, have you had any issues like restoring let's say like a 2.9 or a 3.0 versus a 3.5? Is that the same for you? The super narrow versus the regular narrow?
question. Yeah. I mean, fortunately, you've been doing this as long as I have. Excuse me. I don't mean that. You've seen a lot of these cases. So when Straumann first came out with the 2.9, I was actually one of the ones that was just starting to do them first. And then, the good news is, before Straumann, and I don't know if Nobel came out with it first. Forgive me. I don't know if Nobel's 3.0 was out before the Straumann 2.9. But in essence, before that, we had to use one-piece implants, in those areas if you wanted to go real narrow. And I'm very opposed to one-piece implants in the anterior. I just don't get a good emergence profile. I don't get all the things that I needed from it. And the reason it took so long for Straumann to get a 2.9 is they couldn't get FDA approval, because prior to that, the FDA thought that the materials would be too fragile and they'd snap for a 2-piece implant. But as far as emergence profile and things, I'm always using custom abutments, so things are going to be a little easier because we can shape them the way we want, and then I'm going to tissue shape it and all the kinds of things that I still talk about in lecture, but in a different section of it. because obviously I want to create something that looks like it grew there. And maybe that's the reason I haven't had much struggle with these types of cases. And the reason is I probably spend, if you have a son and he was in my chair, I'm going to spend 2-3 months just tissue shaping the case with provisionals, because I'm not going to jump to the finals until I have it right where I want it to be. And then we're going to. So yeah, I don't mind taking up more time. It's my OCD coming out of me. I'm just going to get it to where I want it, and then we're going to move on forward. So maybe because of that, I haven't had those issues.
Okay. And then, yeah, I like the point you're bringing up about addressing the bite and creating a situation where you're not busting off the Maryland bridges and all that type of stuff. Because I've seen that as well, where they have a deep bite, they have bridges come off, or the braces come off, then you get Maryland bridge, and then those are breaking. And like you say, you get these people who get tired of it, and the tooth busts off, especially if it's a male who doesn't care too much, and then the Maryland bridge is off, and the teeth collapse in, and then they come back and like, okay, let's do the implant. And you're like, well, we got to start all over. We have no space, so that's a frustrating experience.
Oh, it's, and you're so right. It's, this wasn't with Maryland bridges. I'll tell you a funny story. I had this young kid, the one I was telling you about, and he'd come from another office, and he had a flipper, and unusually it was keeping the space, which is, you never know which ones are teeth, the roots are going to migrate and don't. But it turned out it was working, so we didn't change anything, and he only needed to wait about another year before we were ready for the implants. But he ended up going to college. He went to a keg party, and he got drunk and threw up, and he flushed his flipper down the toilet.
Nice.
And you know what? He thought it was like a gold, a medal on his chest. He thought it was hilarious. I'm worried stiff, because it's like, I'm thinking the teeth are going to move and all these kinds of things. So you're right. The males are, they have a loose wing. They just kind of play with it. Oh, I just was playing with it, my tongue. I'm not going to worry about it. That's why the information from the parents needs to be and I literally give them instructions. And I hate to say this, but I try to scare the parents. I go, listen, if this thing comes loose, he needs to go to a dentist up there, or he needs to go to somebody down here. And if he doesn't do that and that root moves, you're going to start braces all over again. So I really push that. So they can't say that I didn't tell them and I didn't emphasize it. So once we get to the point where the Maryland bridges are off, you're placing the implants, and hopefully it's guided, and we're doing that now. And we've gone through the 3A 2B rule of how to put them in. Now, the only thing I see that's a big gap, and I just referred to it, is how are the restorative dentists handling the occlusion of these things?
Yeah.
Because I always say this to my surgeons, and I don't mean this in a bad way, because I'm going to say this. I would say this about me 15 years ago than I would another GP, is if I was a surgeon and I was sending out all these implants to all over my city, I would be worried stiff about, does this person understand occlusion? Does this person not understand occlusion? And you're sending it, and you have very little control of that. As Carl Misch said years ago, the majority of reasons for implant failure is occlusion. That's just a reality. And if the dentist doesn't understand that, over long term, we can have broken screws, chipped crowns, God forbid, loss of integration, and those are problems. So the two things I stress with anterior, I'll just talk about the laterals, is the dentist needs to understand two really, really important things. Number one, when the patient is in a normal closure, or CO, centric occlusion, the lateral incisors, or the implants, just like it would in the posterior, shouldn't be touching unless they're in a clench. So I actually use shim stock. So I'll put it in, and I'll just have them close in a regular, not clenching, just normal bite. And I should be able to pull that shim stock through on the lateral. When they clench, it should stick. Okay? And some dentists understand that, and some dentists don't. What they need to understand is this. The other teeth have PDLs. When the person clenches, they're going to move out of the way. So I don't set lateral taking the full load when the patient clenches. So what we teach in that. And then, have you ever, and I don't mean to ask you, put you on the spot, do you know what crossover is?
Tell me.
Yeah.
I'm sure I learned that at some point.
The average dentist that does aesthetic work doesn't really get this. And this is such an important aspect of restoring not only lateral implants, but upper veneers, everything. The most common veneer that breaks off on upper veneers is a lateral incisor.
Okay.
Why? Crossover. Okay. Now, and if the dentist doesn't know this, they'll get a patient coming back 3 or 4 times for a broken lateral veneer, and they'll make another one. And if they don't do anything about it, it's going to happen again and again. Same thing with an implant. Now, what's crossover? Grant, if you went to, let's say you went left lateral off your canine.
Yeah.
Okay. Now go past your canine. What are you landing on? Some people land on the central. Some people land on the lateral. What you want to do is you have the patient move left, far right. And if you land on the lateral, get it out of the way. Let them land on the central because the lateral is the implant. So you have to get them out of crossover contact. Now the patient says, I don't go that far. Well, when you sleep, you do. Okay. So the last thing I always check is number 1, shim stock. Number 2, contact and a clench. And number 3, is there no lateral crossover contact on my implant, or in some cases just veneers, because ultimately that can be a problem, and that's going to be a more long-term problem. And then you're going to end up, why has this been in the mouth for a year and now I have a loose screw? Why is this? It's a micro trauma, and ultimately it's something that's not going to happen right away unless it's really out of whack, but it's going to happen over time. So eliminate crossover and get a centric stop that's only in contact on in a clench, and those 2 things tend to go away. And then lastly, it's just a matter of getting the aesthetics right. So the challenge with all these things, it's long term, and that's why the protocol becomes so important. Is one phase when they're 9 or 10, you're going to be at one phase in the protocol. When they're 14 or 15, you're going to be in the provisional state, and then when you're in the 21 to 18, you're going to be in the implant phase. And how do we handle each one of those, definitively, so that we're all on the same page? I think the hardest challenge for me, and this is probably works out well for me because I do stick with one specialist for the most part, is when I travel, especially, is finding. I tell the surgeon and the restorative dentist, even if you have 1 or 2 orthodontists that really, really understand this, and maybe the other ones don't. This is where, if I would send the patient to the orthodontist, that's who I would send it to, knowing that I'm going to have to deal with these things later on. Okay. If you inherit the case from an orthodontist, that's a whole nother standpoint. But you should be able to, without hurting anybody's feelings, take control of the case and say, listen, this is how Grant and I prefer to treat this case, meaning wait for this, do Maryland bridges, all those kinds of things, and ultimately finish the case. Because ultimately, once you put the implant in, as you know, Grant, you can't take it back out. It becomes a mess, and ultimately the patients are dissatisfied. And what I always say is, parents and patients and anybody, when you have a problem with an implant, they don't think of the problem. They think implants don't work. They think implants have a bad name.
Yeah.
It's not that. It's that maybe the protocols weren't followed at the level where very, very careful. I think the restorative dentist, if I were going to say one thing to them about these kind of cases, is there's no hurry. You got to eliminate that out of your vocabulary, because these are long-term cases, and I would rather wait too long than put the implant in too early.
Yeah. Yeah. From the surgical perspective, I think these can be tricky, mostly just because they're narrow spots. The more narrow it is, like you're saying, the more precision there has to be. And so, I've gotten multiple cases where it's sent to me and the space is very narrow, probably like 5 millimeters or sometimes less. And, sometimes as a young surgeon, you're just kind of like, well, maybe let's just deal with it and put an implant in there. And it never goes well. So I think we need to be, also know where our kind of limits are and say we absolutely have to have this amount of space. And here's
are you seeing these cases for the most part? And this is a question that I have. I'm not saying I know the answer. Are you seeing these cases after the ortho's off already for the first time?
I would say probably like 70% is with the orthodontist I work with, they're doing our protocol. I see them with the braces on, but yeah, I'll get 20, 30% that it's, years after braces. I've never seen them. They just show up and like, oh, let's do implants.
Yeah, and that's a challenge because, as you said, like as a young surgeon, you don't want to offend anybody. You don't want to look at the case and go, and then no matter how nice you say it, you come off as being difficult. Okay.
Yeah.
Because, he wants me to put the braces back on. Well, when I do my anterior lecture, the first thing I open up with, which is for the first 10, 15 minutes, is all these failure cases that, because I've been doing this type of lecturing for years, restorative dentists and surgeons tend to send me these photos of cases and what do I do here? What do I do here? What do you think about this case? So I have this 10-minute lecture on all these failures. And 90% of them, granted, some of them are, obviously the implant out of the buccal plate and things like that, but most of them are aesthetic failures. Mm. And the challenge with that is the fix is worse than the problem. Taking the implant out, grafting the site, it's usually multiple procedures. You got to do a guided bone regeneration, then you got to do the tissue, then you have to do this. And you still can't look at the patient and promise it's going to look like it grew there.
Yeah.
Getting everybody on the same page is tough because a lot of those patients included haven't seen the failures.
Yep.
So they just think it's never going to happen to them, right? And you have, and I have, and I look at it. And that's why I'm so probably overly careful. Is I've seen a lot of failures because of these cases I've been sent to evaluate, and in my hands, I'm going, listen, I'll wait another year before I put that in because I know what can happen.
Mm-hmm.
Okay. When you get that passionate about it, you won't have a problem going, nah, this person isn't ready yet, or this patient needs to go back in ortho. And that's hard for you because you're a referral business, right? You're this in a whole different mindset than me. I'm the one that's kind of in control. I can say, no, we're not doing this yet. You have a problem because you have all these referrals that might find it difficult, but they need to understand. And this is why the lecture that I do becomes so, useful for surgeons is they have all their general dentists in the room. It's usually sometimes 30, 40, 50 people in the room. And I've shown them all these cases. And now after I'm done with this lecture, very few of them are going to ask, can you put the implant in early? Because they're, I remember when Vic showed me this or this, well, let's wait a little longer, And now it's not that friction between your restorative dentist and you. And, obviously if you have a prosthodontic, they already know all these things. It's a non-issue. But ortho needs to learn it more and, maybe you could do this now, have a lecture with with your group and your orthodontist and say, this is why I want this, this, this. And I've said to you, when I sent you these forms, you're more than welcome to share my protocol form that I sent you and send it to your GPs and your restorative dentists and your orthodontists. It's fine with that. And you can also send them the, the release form, because I think that's a biggie. I think it's going to save a lot of headaches in the long run. So, and then lastly, if your listeners want these forms, I think my email address is going to be within the contacts. They can email me and I'll just send them, I'll send them a PDF of this and they can, I think my logo's on the top, but they can take that off and do whatever they want and send it to their GPs or restorative dentists and orthodontists. I think it's important that everybody takes a look and understands where you're coming from.
Yeah. I love that you created this protocol and these documents that help the whole team be on the same page, help the parents know what's going on. Such a helpful thing, and it's a good review for us. I like too that you mentioned. I mean, because I'm always concerned more about the surgical aspect, but having a guide, working with your restoring doc to know the exact depth and spacing you want there. It's so much better to just get all that double check beforehand than freehanding an implant and kind of guessing.
That old adage, measure twice, cut once. It's that thing. And Grant, am I right? You said you have 6 kids, right?
Yep.
I mean, I tend to look at everything like this. And I know this sounds cliche, but for me, it's just so true. If this were my kid in the chair, would I want it guided? Absolutely, I'd want it guided. Would I want this? Absolutely. Would I want to wait if I know it could be a better result? Absolutely. So those are the kind of things that I try to just treat every restorative and patient as, listen, if this was my parents or my kids in there, what would I want to do? And the last thing I want to do in this type of case, the anterior cases, is be in a hurry. And if you were my surgeon and you didn't want to do a guide, I'd look at you and go, I'll buy you the guide. I'm fine. You're gonna put a guide because it's my kid, right? It's like,
Sure.
but ultimately it works out well because everybody just seems to as long as this is the important thing. Everybody just wants the best result for their patient.
Yeah.
If you just think about that foundationally, everything else is just extra, And when they stop, and I understand the GPs want to increase their production and things. I get it. I really do. But there's certain things that can't be done quickly, and this happens to be one of them. So.
Yeah. And such a critical area to someone's smile. I mean, you really want to be taking your time and getting it this perfectly right.
Yeah, it's a situation, and it's kind of like what I alluded to, a few minutes ago. Is don't forget, this is something they're going to smile and look at in photos, in their wedding photos, when they brush their teeth in the morning. They're going to look at this tooth every day of their life.
Yeah.
Why not take the time to make it as best you can? And even then, it's not easy. I don't think the protocol is complicated. It's just it takes time. It really, it's something that will work out well. I don't think there's anything that I talk about or you talk about that's not within the skill sets of everybody listening. But I think it's just something that, take your time, do it right, do it well, and you won't have any issues in the long run. So.
Expectations of the patient and the parent, all that stuff.
Yeah, that reminds me. Like when I finish this parent instruction sheet, I'll send you a copy of that, and then any of the listeners, because I think it's really important just to, what you just said is the perfect way, lower their expectations, meaning make sure they understand the age, make sure all these little steps are involved. And that's what I'm going to put in there so they can just hand this to a patient, the parents, and go, here's our protocol. And the good news is, if you put it in a Word document and you change your protocol a little bit, you just tweak it. That's what I do all the time anyways.
Yeah, perfect. All right. Well, if you're good with it, I'll put your email and then link to the article you referenced.
Yeah.
And
the listeners email me. Just tell them to put in the subject laterals, and I'll know what to send them the protocol sheets.
Okay. Sounds good. Thank you, Vic. I appreciate you.
Hey, buddy.
Have a good one.
You too.
Thank you so much for listening to this episode of Everyday Oral Surgery. For more information on these podcasts, please visit everydayoralsurgery.com. I love feedback and would be very grateful if you would reach out to me via my email, grantstucki@gmail.com, and let me know what you thought of this episode. Or you can text me at 720-441-6059. Additionally, if you have any topics you'd like to hear about, or if you would like to be a guest on the podcast, please email or text me. I found many of my interviewees through people who have been contacting me and have been listening, and I've gotten so many great ideas for more podcasts, and that's what helps keep the podcast rolling. So I really appreciate you making that extra effort and helping me out with feedback and knowing what to do next on the podcast. Thank you so much.